So we know that stem cell mutations happen with aging, what we call CHIP mutations or clonal hematopoiesis of indeterminate potential. Now, that happens with many of us as we get older, but when it starts happening also with multiple myeloma, the question is whether this stem cell aging is leading to inflammation and changes in the immune system, and that leads to myeloma progression or not, and whether there is an interaction between the stem cells or the CHIP mutations and the myeloma cells. Now, for us to answer those questions, we went back and looked at the stem cells collected during transplant from 600 people who were seen at Dana-Farber, and we had a long time of follow-up in those patients so we can understand better what happened. Did that worsen their survival or not? Did they have worse progression of myeloma? And what is the effect of immunomodulators, lenalidomide and thalidomide on these patients? We know that Revlimid or lenalidomide post-stem cell transplant can be associated with a higher risk of MDS and leukemia. And the question was, if you're already having a stem cell damage, if you already have a stem cell mutation, should you avoid receiving Revlimid post-transplant or not? And in fact, should you even be getting transplant with high-dose melphalan or not? So these are all important questions, and I think we started the conversation by that first manuscript, but there are so many questions to be answered here. And what we showed is that in those 600 patients, the rate of CHIP mutations was indeed elevated in multiple myeloma. About 20% of those patients had it, and that's relatively high. And when you look at just having CHIP mutation, yes or no, indeed, the survival was different. Patients who have CHIP mutation have a worse survival, which is very similar to all of the other studies of CHIP mutations. They have a worse survival. But the most interesting question, and what surprised me, is that patients who had Revlimid or thalidomide maintenance and had CHIP mutation, there was no difference whether you had a CHIP mutation or not. It sort of abrogated that bad prognostic variable. Now, we have to take that in context with the overall survival of myeloma. We know that Revlimid can make a difference in the survival of myeloma patients. So it was the worst survival of myeloma that overtook that, and having Revlimid the benefit from it still outweighs the risk of having MDS and leukemia in those patients. We also know that those CHIP mutation patients did indeed have a higher risk of MDS and leukemias. We also know that potentially the certain types of mutations may be different, that maybe overall, in general, if you look at all CHIP mutations, yes, the effect of Revlimid may be the same. However, if you have a p53 mutation, and this is what we're trying to show now in the future, maybe that could be worse if you have Revlimid. Maybe that clone will grow more if you have Revlimid. So there are so many other questions that can be answered here. And truly, this is important clinically. We see every day patients with multiple myeloma. We decide whether we're going to transplant them or not, and we decide whether we're going to give them Revlimid maintenance or not. And with that in mind, whether you have a CHIP mutation can make a difference whether you're going to take that patient for transplant, for Revlimid. Is it a p53 mutation? Should I track it or not? Is that the reason they have cytopenias? All of these are clinically important questions.